All right, let's get right into it. Today, we're diving into a highly authoritative clinical guideline from the Royal College of Obstetricians and Gynecologists. We are going to build out a step-by-step playbook for navigating a really scary, sudden pregnancy complication. If you're invested in maternal-fetal medicine, or, just want to understand the incredible modern protocols saving premature lives, this explainer is going to take you right to the front lines. We're going to decode the exact steps doctors take when the protective barrier around a baby breaks way too soon.
Here is our roadmap for this explainer. First, when the bubble bursts. Then, confirming the diagnosis, followed by the medical defense strategy. Next, we'll look at the neurological shield, the waiting game, and finally, healing beyond the physical.
So, Section 1. When the bubble bursts, understanding the stakes. Let's look at what we're actually dealing with here.
To put this into perspective, we really need to understand the sheer scale of the issue. Now, this specific complication affects up to 3% of all pregnancies. And I know that might sound like a small slice of the pie, but remarkably, it is responsible for 30 to 40% of all preterm births. Think about that for a second. More than a third of all premature babies are born early because of this exact trigger. Let's define exactly what this is. PPROM stands for Preterm Prelabour Rupture of Membranes. In everyday terms, it's when the amniotic sac, that amazing, protective, fluid-filled bubble around the baby, breaks before 37 weeks of gestation and, crucially, before labor has actually started. The protective seal is just gone. And that brings immediate severe risks, mostly from prematurity, ascending infections, and cord prolapse. The clock starts ticking instantly, and the clinical response literally has to be flawless. Moving on to Section 2, confirming the diagnosis, the investigative phase. The step-by-step investigation doctors use to confirm if the water actually broke is fascinating. Because, it's not always like the movies where there's this massive, obvious gush of fluid. Step 1 relies heavily on maternal history. What the mother is reporting is paramount. Step 2 is the gold standard, a sterile speculum exam to physically look for pooling amniotic fluid. If the doctor sees it, boom, diagnosis confirmed. But what if it's kind of borderline? That actually happens in 10 to 20% of cases. That's when we hit Step 3, turning to specific vaginal fluid biomarker tests called IGFBP-1 or PAMG-1. These biochemical markers are incredibly sensitive and act as a super reliable tiebreaker.
Okay, so once PPROM is confirmed, the absolute biggest immediate threat is an ascending infection called chorioamnionitis. Because the stakes are so high, doctors simply can't rely on just one test to spot it. They have to use a combined clinical approach. They're constantly cross-referencing mom's vitals, like pulse and temperature, checking the baby's heart rate, and analyzing maternal blood tests for inflammatory markers. A single isolated test, like C-reactive protein, it only has a sensitivity of about 69%. By combining all these metrics, the medical team casts a much tighter safety net to catch any infection early.
Which brings us to Section 3, the medical defense strategy, buying time and protecting the baby.
This is where strict clinical boundaries come into play. And honestly, it's just as much about what you don't do as what you do. The do's are clear. Give the antibiotic erythromycin for 10 days to drastically cut infection risk and delay birth, and absolutely give corticosteroids. But look at the don'ts. Doctors strictly avoid an antibiotic called co-amoxiclav because, wow, the data shows it can actually cause severe, life-threatening gut issues in the premature neonate. They also avoid tocolytics. Those are medications meant to stop contractions. The research is completely clear here. Trying to chemically stop labor in these cases just increases the risk of maternal infection without improving outcomes for the baby at all. And finally, routine amnio infusions, basically pumping fluid back into the womb, are an absolute no-go for routine practice.
Let's look closer at those corticosteroids, because they are a total game changer. They are this vital defense mechanism used to rapidly mature the premature baby's lungs and prevent severe brain bleeds. The clinical guidelines lay out a very specific timeline. From 24 weeks up to roughly 26 weeks, they're offered. Between 26 weeks and almost 34 weeks, they are aggressively, strongly recommended because the evidence of their life-saving benefit is just that high. Once the pregnancy hits 34 to 36 weeks, the risks of extreme prematurity drop off a bit, so the steroids are evaluated and considered on a much more individualized basis.
Section 4, the neurological shield, defending the baby's brain.
This next intervention is honestly one of the most fascinating parts of modern obstetrics, and it happens right before birth. If a planned preterm birth or established labor is happening within 24 hours and the mother is before 30 weeks of gestation, intravenous magnesium sulfate is the absolute intervention of choice.
So why magnesium sulfate? Well, because it's effectively a miracle for the fetal brain. When given to the mom right before birth, it acts as a literal neuroprotective shield for that fragile premature infant. The clinical data proves it significantly slashes the lifelong risk of cerebral palsy and reduces motor dysfunction in the child as they grow up. The window of greatest benefit is right up to 30 weeks of gestation. It's just a brilliant example of using maternal medicine to permanently protect a neonate's future quality of life.
Next up, Section 5, the waiting game, deciding when and where to deliver.
So with the immediate medical shields in place, we enter a period of expectant management. It's a careful balancing act to buy the baby more time in the womb. And a natural question for any anxious parent in this terrifying situation is, do I have to stay confined to a hospital bed indefinitely? Days can easily turn into weeks, right? So what does the evidence actually say?
Surprisingly, home monitoring is actually possible, but on a highly individualized, case-by-case basis. Studies show no major difference in negative outcomes for planned home care versus hospital care, provided some very specific boxes are checked. If mom is stable, has good support, and lives close to the hospital, outpatient care is absolutely an option. But doctors mandate hospital care if there are critical red flags, like if delivery looks imminent, if the rupture happened extremely early before 26 weeks, or if there's dangerously low amniotic fluid. It's really all about empowering the patient with comfortable care without compromising that tight safety net.
Now, how long are we actually waiting? It is fascinating how the timeline shifts based on when the rupture happens. If the membrane ruptures early between 24 and 28 weeks, the median wait time, the latency period before birth naturally kicks in, is about 8 to 10 days. It's almost like the body tries harder to hold on when it knows the baby is extremely premature. But as the pregnancy advances, say to 31 weeks, that median latency window shrinks down to just 5 days.
The ultimate goal of this entire playbook is to dispel a massive myth, that if your water breaks, you must deliver the baby immediately. Sure, that's true at full term, but with PPROM, early delivery actually skyrockets the baby's risk of respiratory distress and neonatal death. The clinical guideline clearly states that as long as the mother and baby remain stable and free of infection, doctors are going to hold the line and use expectant management all the way until 37 weeks. They literally let the baby bake as long as safely possible.
Finally, Section 6, Healing Beyond the Physical, the Postpartum Reality.
We really have to resolve our timeline by acknowledging a factor that medical charts often miss entirely: the immense emotional weight carried by parents navigating this emergency. The physical trauma might end at birth, but the psychological impact lingers. And the data here is incredibly sobering. Compared to a routine pregnancy, where postpartum PTSD rates sit around 3%, a startling 17% of women face severe post-traumatic stress disorder 6 weeks after giving birth following PPROM. Sitting in that hospital bed, constantly checking for infection, wondering if your baby will survive early delivery, it takes a massive psychological toll.
So the final takeaway of this explainer is this: empathy, counseling, and mental health support are just as crucial as the antibiotics and the steroids. We have these incredible medical shields for the physical body, but emotional support must be treated as a clinical necessity, not just an afterthought. When the medical playbook is perfectly executed, mother and baby survive. But moving forward, we really have to ask ourselves, how can our healthcare systems better shield the minds of the families navigating this incredibly high-stakes journey? Think about that as you process this data, and thank you so much for joining me to unpack this crucial clinical guideline.